Hey guys, I'm here with Andrew Millett of Movestrong Physical Therapy. Andrew, what's going on?
How you doing?
I'm doing awesome. So, I got to start with one question, and one question alone. Are you ready?
I think I'm ready.
You think so?
No, I know so.
Are you sure you're ready?
Positive.
Okay, so my question is, if a tree falls in the middle of the woods and no one's around to hear it, does it make a sound?
Yes.
Why?
Because I said so.
Because you said so?
Yeah.
But how do you know?
Oh. There's always something around to hear it, some living being.
So if you can find that living being, whether fox or mouse or hawk
Or honey badger.
or honey badger, do you like honey badgers?
Yeah, that's a pretty cool animal.
They're pretty cool. Yeah, they're not bad. So the tree does make a sound.
Yes.
Is your final say?
Yes.
Okay.
Final
deal.
answer.
So we're gonna get right into it then, since you've already been thinking about a long, hard life question, a little tiny bit. But so how this physical therapy business? A lot of people are into it. A lot of people have questions about it. How did you get started in all of it? Where's your journey?
So I was a 3-sport high school athlete, and ironically never got hurt. Like, banged up like little tendonitis here and there, but no like catastrophic injuries. And I saw a lot of my athletes that I worked, or teammates that I worked with that got hurt, or family members that had injuries when I was younger. And I want to continue to work with athletes even after my career was over, after 2 years in college, playing sports. So I wanted to still be involved to some extent, not necessarily playing, but helping out and like helping out the athletes, move and feel better. So I went into PT school in 2003 at Springfield College out in Western Massachusetts. And then in 2008, after a bachelor's and master's degree, graduated from there. And as I was getting into the PT curriculum, I actually tore my ACL.
Oh, geez.
So it was, I knew I had made the right choice, and this is before I knew how to rehab paper ACLs, but I knew I'd made the right choice because I'm like, looking back, obviously you don't want to go through an injury like that, but it helps give me the appreciation of what my client or athlete on the table is going through, physically, mentally, psychologically, after either a major injury or a minor injury, like a ankle sprain or muscle sprain.
Gotcha. So who are the most common people that you have as patients or clients?
I see everyone from the high school athlete. I've treated up through high school, college, Olympic level, as well as professional baseball players as well. I like working with all different populations because it keeps things a little bit different. Like, you get the high school lacrosse player, and then you get the minor league baseball player. But I also, enjoy working with the CrossFit athlete too, whether it's someone who's competing or it's someone who is just looking to get a good workout in and stay healthy and move better. Whatever their goal is works for me. So I love working with different types of people.
Gotcha. And sort of along the lines of like injuries, what are some common injuries that you see in sports? Is it a lot more sport related where it's very case dependent, or do you see sort of commonalities in a lot of these injuries?
You see a lot of the traumatic sports injuries like your ACL tears, your shoulder rotator cuff or labral tears that have either been one macro traumatic event that occurs and that's when they're injured, or you can see a lot of micro traumatic events that, if someone doesn't move optimally over time, it's kind of like a little kink in the armor per se, and then that just builds and builds and builds, and then most people don't notice it until they're in pain. And a lot of people will, they'll come in pain, but there's other factors that we can look at movement quality wise that can say, oh, you're moving a little bit differently, whether because of the pain or a lot of these things could have led up to this point.
So what are some of those things that you could say are kinks in the armor?
So I'd say, if someone lacks mobility at certain joints throughout the body. So all the joints in the body have a certain mobility prerequisite, if you'll say. So like say the shoulder, you should be able to get the arm fully overhead, or a certain distance across your body, or the hip, like with squatting, like you should have enough internal and external rotation, moving your hips side to side, to be able to perform a squat safely and effectively. And if you don't have those prerequisite mobility requirements, that can place more stress locally on that joint as well as other places. So for example, like if someone lacks hip mobility that could affect the hip itself, or it could contribute to low back pain or knee pain. So a lot of times in my practice, like if somebody comes in for knee pain or shoulder pain, we're looking at the painful joint. We're also looking the joints above and below to see, hey, are there other non-painful areas that could be contributing to this?
Gotcha. So what's your approach when you have someone come in new through the door? What's your approach to get them to a healthy place?
Before I even have anyone walk in my door, if someone either emails me, they call me, they text me, I hop on a phone call with them. And I want to hear their story. I want to hear where they're at, how did this all start, how it's affecting their life. And the most important question is, at the end of the day, like, what do you want to get back to? So 99.999% of people want to get out of pain, but there's a deeper question to that. What is that pain limiting you from doing? All right, so you have low back pain. Oh, I can't deadlift off the floor. Okay. Or I have low back pain. I can't pick up my kids. Yeah. That hits home for a lot of people, that like they're able to do something before and now they can't. And it's not just about the pain, it's about what they can't do in their life that's really deeply affecting them. So I hop on a phone call with all clients before I even meet them to get a feel for what's going on, find out their goals, different treatments they've tried in the past that might have worked or haven't worked, and then we have them come in for an assessment. And then I basically sit down and talk with them some more, just kind of ask different questions that you need to ask in person, can't see over the phone. And then we go through a full assessment. And it's basically a movement assessment. I just have people do different things like bend over, touch their toes, lean back, reach overhead, and do different shoulder assessments that are tough to say in the audio format to describe. Yeah. But what that does is it's a top tier assessment that gives me feedback on how somebody prefers to move. Mm-hmm. And then what I do with that, I take those movements that don't meet kind of the baseline of what we expect, and then we break them out and look at those movements in isolation and see if there's truly a mobility limitation that's driving that, which a lot of times it is, but maybe they don't have the control of that joint to get in the right position. So whether it be shoulder, hip, knee, low back, the assessment's similar, but how we break it out and examine each joint, and is it truly a mobility limitation or more of a motor control or kind of a stability issue?
Okay, so I know we tend to focus so much on mobility, and I feel like that's a lot of people say they can't do something because they're not mobile enough. So how do you usually, what do you like to approach mobility with? How do you like to attack that?
So before I even, assess mobility, I look at position. So, if someone's just standing and, there's healthcare practitioners out there that say, well, static posture doesn't matter. And like I say, it's a piece of the puzzle. It's not the whole puzzle though. Mm-hmm. So we look at their position, and then we look at their position and how they move. So are they compensating in some area, or are they distributing movement throughout the body? So like whether it be a squat, are they butt winking at the bottom? Are they going to like a heavy arch when they go to squat down? That's giving me information on how they move. So that's how their position is. Now they may be arching their back because they don't have enough hip flexion mobility, or they may be rounding their back because they don't have good core control. So that position is kind of the starting point of like, all right, this is how they're moving, and this is how they're starting, but why? So then I go to mobility and say, all right, I get them on the table, I check their hip mobility, I check their shoulder, and per my baselines of what I know it should look like, or in my experience, then if they exhibit full mobility, then I know their mobility is there, that they have, or they don't. And then we address the mobility through soft tissue techniques. I do dry needling, pin and stretch, different hands-on type things like instrument-assisted soft tissue cupping to help improve that mobility. Because before you need to have the prerequisite mobility in order to move, and then the prerequisite stability or control of that mobile joint afterwards. Mm-hmm. So if someone has full shoulder mobility, then I'll have them move actively at their shoulder to see, hey, do you have as much control over this mobility that you think you have? So if they can get their arm flat on the table, can they get there themselves actively? And that's how I assess that.
Can I jump in with a question? I don't know if I'm on the camera, so I might have just like randomly come out of nowhere.
Came out of the woods.
Just came out, yeah. Heard you guys talking, and it sounded like an interesting conversation. But my question with regards to the mobility side of things is, do you ever have that conversation or you might not, with clients on time frame, like expectations, because that's one thing that I think a lot of our members or just clients in general, either they're unsure of, or it's something when we discuss it, it just sets that expectation so they feel a little more comfortable or confident with knowing, like, okay, this is going to take me 6 months, or this is going to take me 6 weeks, versus like, oh, hey, I did this twice a week for the past month and I haven't noticed a change. Like, where's that does that conversation come into play, and what does that look like?
Daily, all the time. So I'm kind of an impatient me personally, not with my clients or anybody else, but if I'm treating somebody, I want to see an immediate change. So whether I dry needle somebody, I cup them, I do instrument assisted, like if we notice somebody has a limited, say, shoulder flexion, like getting their arm overhead, from a mobility standpoint, I want to do a hands-on, manual therapy treatment to see, one, is there a change? Two, if there's a change, is there a change in the person's symptoms? And if we see a change, we know we hit the right spots. So if I, dry needle the lat and the shoulder mobility improves 15, 20 degrees, then I know we hit the right spot. Now, the thing with manual therapy is that, or any type of exercise, it helps open the window to good movement. So if you foam roll, or you do self-myofascial release, or you smash with a lacrosse ball in your quad or back of the shoulder, or more hands-on specific stuff like I was just speaking about, that opens a window to good movement quality. My approach is that I give my clients and athletes correctives and just a few to help maintain the improvement between sessions. So if a client of mine, we dry needle them and they go home and then their tightness comes right back and they're the same as when I first assessed them and the change didn't stick, either I'll own it, I worked the wrong spot, I didn't give them the right exercise, or they didn't do their stuff. And I'll have a frank conversation and be like, listen, did you do your stuff? And most of my clients are pretty honest with me. I don't get mad about it. But I say, listen, you have to do stuff between our sessions to maintain the improvement, and also to take ownership of what's going on. So I usually give my clients a 5-minute routine to do daily. I don't like to exceed that time. That way, that can help maintain the change.
And with that change that comes in, I don't know whether it's a percentage base or just based off of your past experience. When you see a client or all the clients that you have, what percentage would you say, or maybe not even percentage, but a majority, would you say all they need is things that they can do themselves? Let's say whether that's foam rolling or using a lacrosse ball, to working with, let's say, maybe a banded overhead distraction, whatever it is, versus requiring that hands-on work. Is there 20% that need the hands-on work, or is it, and if we're talking from a mobility restriction standpoint, or is it hey, if I have someone coming to me, usually the majority of the time, they're going to need some sort of work done, body work, whether it be, like you said, that instrument assisted or cupping. What does that look like?
Yeah, so the majority of my clients I see once a week, and that kind of ties into my business model of I see my clients once a week to, one, give them the independence to take control of this and stay ahead of it, so that in a year from now, when they're feeling really good, if they're on vacation or they're not in, quote, physical therapy anymore, if this issue comes back, they have the tools to get ahead of it again. Say, oh, Andrew showed me A, B, C, X, Y, Z exercises or movements or foam rolling to get myself moving and feeling better. So typically after the assessment, I'll make at least 1 or 2 follow-up sessions about a week or 2 later, depending on scheduling for them. And we'll follow up, we'll do a quick reassessment, just a couple movements to see, hey, how did that hip look compared to when you left last time? So that gives me some information of how they're currently doing compared to when they left. So typically my clients I'll see once a week, and then we taper down to every other and more on an as-needed basis, more like a movement checkup. So every 3 months, we have my athletes will check in, even if they're feeling great, just to run them through these quick movement assessments so that we make sure everything's firing on all cylinders and tapering off to allow them to be more independent and have control over what they need to.
Gotcha. So is this something with CrossFit athletes that you see common, that they tend not to do the little things that are important, or what would you usually say is a common reason why you see some CrossFit athletes come in?
I wouldn't say it's just CrossFit athletes. I figured anyone's a human.
Yeah.
We all have priorities in life, and we all want to do the sexy, fun stuff overhead snatch or deadlift off the floor. no one wants to do their hip flexor stretch or their like activation exercise. I think it's just with humans in general, but like CrossFit and specifically, like, doing your prep work, like doing your maintenance on your car. Like, we all want to drive our cool car like around and it serves a purpose, but changing the oil, changing the tires, which would be analogous to doing your foam rolling or your activation exercises, helps keep the car, quote, car on the road longer, helps you stay in the box and the gym longer so that you're not getting banged up because of an injury.
Gotcha. Is that something that you find sort of, I guess I sort of just asked that. That's what it is. So then I'm gonna sort of go into like the strengthening of, we talked a little bit before about you finding that sometimes the injuries that are caused can happen by sort of like a gumbiness to the person when doing an exercise. So how would you approach someone who tends to be maybe too mobile and needs some work as far as strengthening good movements?
So I find that even if somebody, like, say, can bend over and palm the floor, or then when they lean back, they're gonna do a back bend. Like, more often than not, those people still have some type of mobility restriction somewhere. And this is where you walk a fine line in that you don't just get everyone more mobile. Because that can be very, it's a tipping point of, if I get this person more mobile and they're already mobile, they don't have any stiffness, like good tension like in their core or hammies like to help protect their back and all these other joints. So the biggest thing with whether you're stiff as a board or you're a Gumby is that, we improve that mobility. So say like someone has low back pain, but they can palm the floor when they touch their toes. Well, we might work on those hip flexors because that could be contributing to the pain and their movement quality, but you better bet I'm going to give them something to do between sessions. It may not be like foam rolling or stretching, but some type of exercise to train their brain, because your brain controls everything in your body, to train the brain to control your mobility. So like if you can palm the floor, like, all right, that's great, but we want to train your abs, your hamstrings, and all this other stuff to work together during a lift and just everyday life to maintain and control this movement.
Gotcha. So are there some examples of a few that they could do, let's say, for like a shoulder, for their lower back? Would you have like a couple examples of exercises for people to try?
Yeah, and a lot of it's based off my assessment, so it's like what I see on the table, but like if someone can bend over and touch the palm of the floor, but I get them on the table and their hamstrings are super tight and I can't even raise their leg up, that tells me something that, hey, all their mobility is coming from their back, not from their hamstrings. So they might be able to touch their toes or palm the floor, but their hamstrings are super lit up and tight. Well, what can happen is if you don't have good core recruitment and good core stability, then it's not doing more planks, it's just more about doing exercises that improve the timing and control. That allows the core to function better because it's a stable base and allows the leg to move better. So you could do a core exercise and that leg raise or that hamstring test might improve like 20 degrees because you just train the body to control that position better.
Gotcha. So it sounds like this approach that you've developed and had for a while has adapted over time. What are some things that you've learned as growing through being a practitioner that sort of are big standout reasons why you do what you do?
First off, I learned from people a lot smarter than me, so I didn't come up with any of this system, but like I've just kind of what I've learned over the 10 plus years of being out of school and being in the profession of like seeing stuff work firsthand. Like I have my primary go-tos, like when someone has limited hip mobility, all right, I know this will limit it or this. And if we work on that and it doesn't work, then I look somewhere else. But a lot of the things I've learned is that, you never assume anything. So someone could like come in, say, with shoulder pain and they could look like they can get their arms fully overhead, but if I isolate that shoulder joint on the table, like their arm may move terribly and they just might be arching their back really hard to get their arms overhead. I've also found like, coupling mobility work with being able to control that mobility. I feel like they go hand in hand and back to our previous point about being in the right position. So position, mobility, stability, bringing those together so when you go do a deadlift or a squat or any other movement, everything is right where it needs to be. And I'm not the typical physical therapist that will give somebody a pink dumbbell and yellow TheraBand and go do your exercises. Like load, weight is one of the best correctives out there. So putting load on top of good movement quality is some of the best corrective exercise out there. Putting load on top of, excuse my French, crappy movement quality, like, stuff will start to break down.
Gotcha. Is that something that, would you also add load to some single arm, single leg movements? Do you tend to really try to add a lot of load to that, or is it better to do more voluminous work when it comes to?
A little bit of both. Like, when people come off an injury, like their work capacity or their ability to handle volume might be down because they've been pushing through an injury or haven't been moving at 100%. So building up submaximal work volume over time. So say like they can squat 225 for a nice round number. Like, we're not going to go try 225 the first day. Like, we might start with 135 to a box or 185 and build up submaximal training volume so that when we try to go for heavier weights, we have a bigger base to work off of. So from a volume perspective, it's gradually building it up so that you have a seesaw effect where, like, you just hit the seesaw, so you get an improvement in volume or work capacity, but not so much where they're back to square one and they're hurt.
Yeah.
But back to your point about single arm or single leg movements, I think they're hugely valuable. Like, I don't mean to, just from what I've seen, a lot of boxers do like double leg movements, or you don't see a lot of single leg work sometimes. So in my personal experience, me personally, like, I deal with knee pain once in a while, and when I hammer my single leg strength on my lower body, my squats feel better. So definitely incorporating a little bit of both into any like rehab or performance program is important.
Yeah, especially from like an activation standpoint before doing, like, let's say you're going to do back squats, doing a little bit of single leg work before you go and do some back squats.
Yeah, doing like even something as simple as a single leg bridge, like just getting your glutes firing, getting your core activated before you do that, it's only going to help.
Yeah, it's not the fun stuff either.
No, of course not. It's not sexy. Like, no one likes to do that. But when the client or the athlete sees the difference, like, wow, I can touch my toes and I don't have pain, or I can lean back and I don't have pain, or I can get overhead and I don't have any pain. Not everyone has no pain after the first time, but if they see the change like that, then that means even more, because I can tell them they move so much better, but unless they feel the difference, then it's, once they feel, they're just like, wow, that simple little drill made it all the difference.
Yeah, definitely. So one last like major question. I think this is a great question to sort of end with, and it was a question that a member asked, and it's really valuable. But for people who may be interested in a topic like this, what's a book or maybe a couple books that you would find really valuable to read and try to learn a little bit from?
So this is just for someone like just going to the box to work out?
Yep, this is just your...
No one with a healthcare background?
No.
Okay, good. I don't want to go rattling off stuff.
Just someone who's looking to learn a little bit more about this topic.
I'm not giving a plug to my colleague Eric Cressy, but his facility is just down the hall, so a lot of his material is really good. I've obviously learned a lot from him in person because I'm inside his facility, but also his products that he's put out. I know a lot of people talk about Supple Leopard by Kelly Starrett out on the West Coast. I have not completely read that book, but I know there's a lot of good self-treatment techniques. And the internet, there's a lot of information out there, some good, some suspect, some. So you definitely have to be careful of where you look, but I'm not giving myself a shameless plug, but my whole YouTube page has like over 500 videos of exercises and treatment techniques that I give to my clients on their first session to help them move and feel better.
Where can you find that on YouTube?
So my YouTube name is Andrew Millett, Millett, P as in Peter, T as in Tom, so Andrew Millett PT. You just type that in and all of it will come up.
Awesome.
And I have a website, andrewmillettpt.com, and then I'm all over social media too, so Instagram's where you can find a lot of my stuff.
Yeah, definitely. And then as far as those like online platforms that you should be wary of or be more lenient towards, like try to go and read those platforms, what are some good websites for articles to read from?
Let's see. Like I just mentioned, my colleague Eric, he's got a great website with a lot of good information on it, not just for the overhead athlete like the baseball player, but just shoulders in general and just, from a performance standpoint after injury. Let's see, what other good information is there? TonyGentilcore.com. He's a former colleague of mine. He's a personal trainer in Boston. Puts out a lot of great content just for the gym goer who wants to just stay active and move and feel better. Yeah, there's a lot. I could put together even a post for it, just to like, I'm spacing out right now about different ones, but there's so much information out there. And actually on my I think on my website I have a list of people that I follow that put out a lot of good content.
Yeah, that's gonna be really good to take and watch.
Yeah.
I just had a quick, because I know we're wrapping it up, but I know we had spoken previously, and one thing that you said that stood out to me, and I forget how you put it, but it was, when you look in the bigger picture, it's, if you have to go get some work done, see a physical therapist, see a chiropractor, maybe you're experiencing some acute problems that you need to deal with. Dealing with that is better than dealing with something like diabetes or a different chronic disease.
For sure.
Kind of looking in that bigger picture. That was, from my perspective, really interesting to hear, because sometimes you don't, I know in the past I've interacted with, whether it's any type of practitioner who's had an extensive education, and there might not be a full either understanding or awareness of like what the goals are with CrossFit. We're not necessarily trying to make people better at exercise, but we're trying to take the bigger picture look, and we try to think about how can we make exercise and proper lifestyle sustainable for someone over the course of time, versus saying, hey, look, you're going to end up in the nursing home at 60. And I think from my perspective, having that conversation with someone who's like, hey, look, I appreciate that same viewpoint. We want to do things smarter. It's not that there's just it's not us saying, hey, well, drive yourself into the wall because you don't want to get diabetes. There's always a smarter way of doing
Smarter,
of
not
exercising. But at the same time, like saying, hey, like, let's look at a larger picture. I didn't know if you had anything to add to that or any thoughts on that.
I think the quote, I think the line that I stole from somebody else probably as well was like, if you're active, you're going to see your orthopedist or physical therapist or sports chiropractor or any of those medical professionals. If you're not active, you're going to see your cardiologist. So I'd rather take the orthopedist any day of the week and twice on Sunday. So, but that doesn't mean every time you get banged up, you need to go see an orthopedic. Like, listen to your body. Like, if you feel something just doesn't feel right, not necessarily pain, but, talk to your coach. Like, hey, are there any modifications I can do, or any scaling options, or just getting assessed like by a PT that knows how the body moves and the demands of CrossFit or just lifting in general, so that you're not trying to put a square peg into a round hole every time you lift overhead. But yeah, that's just like with my own training. Like, I think everyone's is made a little bit differently. We're all human, last time I checked, but someone may not be able to straight bar deadlift from the floor. They might have to do an elevated deadlift or landmine press instead of an overhead barbell press. So I think the fact that people are still showing up and putting in the effort and trying to make their lives better, I love that, because it's like there's so many people. There's the easy road, just lay on the couch, eat what you want, and just see what happens when you hit 60, like you mentioned. But it's taking control of your life, dietary, exercise. You're so much more empowered to have control of your life versus just letting your life kind of happen by itself.